All right, let's dive straight into the clinical algorithm for lower limb pain. We're bypassing the fluff today because for test day, your entire decision logic has to start with localizing the pathology top down. You absolutely must learn how to instantly translate a patient's pain location into a definitive diagnosis.
So the crucial point here is that your diagnostic decision tree starts purely with anatomical localization. Before you even think about ordering a single test or, asking about pain quality, you need to anchor your thinking to exactly where that pain lives. Groin pain, that locks you right into the hip joint itself. Lateral hip pain immediately suggests trochanteric soft tissue or nerve entrapment. Moving down to the anterior knee, you're going to think patellofemoral issues or extensor mechanism disease. The posterior knee strongly points to a Baker's cyst or a sneaky DVT mimic. And down at the heel, you're differentiating planar, posterior, or interdigital pathologies based entirely on precise symptoms and the calcaneal squeeze.
And looking at this visual map brilliantly illustrates our first major branch point. That deep red area right in the groin and anterior hip represents true intra-articular joint pathology. Think osteoarthritis. Now contrast that with the lateral side. Greater trochanteric pain syndrome sits highly localized right over the bursa, while a much larger, sweeping area of pain that shoots down the lateral thigh represents myalgia paresthesia. Let's break down that first big comparison. If the vignette gives you an older patient with groin pain that gets better with rest, but worse with activity, you need to check their range of motion. Pain specifically on internal rotation of the leg, along with a gradual functional limitation, is a massive red flag for hip osteoarthritis. Contrast this with greater trochanteric pain syndrome, or GTPS. This classically presents in women over 50, often with obesity or some other lower extremity disorder. They'll complain of chronic lateral hip pain that flares up the second they lie on the affected side. You'll find highly focal tenderness right over the trochanter. For GTPS, you'll order an X-ray just to rule out hip joint pathology, maybe use an ultrasound if needed, and treat it with activity modification, physical therapy, NSAIDs, and steroid injections. Now, what's literally a game changer for this next lateral thigh presentation is that it completely spares the motor pathways. Myalgia paresthetica is an entrapment of the lateral femoral cutaneous nerve. You'll see this from compression via tight clothing, obesity, pregnancy, or even as an iatrogenic injury. The patient is going to report paresthesia and decreased sensation sweeping down the lateral thigh, and this is key, their motor strength and reflexes remain entirely normal. Treat this by advising weight loss, avoiding tight garments, and giving NSAIDs or gabapentin. If it's refractory, be ready to select a nerve block or surgical release as your answer. Moving down the leg to the knee, your physical exam maneuvers are absolutely your primary diagnostic tools. In orthopedics, your hands dictate the next best step in management. You need to know exactly where to apply physical force to isolate the medial collateral ligament, the anterior cruciate ligament, and the meniscus. I want you to frame your narration of these maneuvers as a strict if-then algorithm. For a suspected MCL injury, you perform the valgus stress test by stabilizing the lateral thigh and applying outward pressure along the medial leg. If you feel laxity, that's an MCL tear. For the ACL, the Lachman test is your go-to. Put the knee at 30 degrees of flexion, stabilize the distal femur, and pull that proximal tibia anteriorly. Anterior laxity equals an ACL injury. For a meniscal tear, you're using the Thessaly test, having the patient rotate on a flexed standing knee, or the McMurray test, doing passive flexion and extension with rotation. If you find pain, clicking, or catching, boom, you've confirmed a meniscal tear. This matrix right here is incredibly high yield for evaluating anterior knee pain in young athletes. It essentially forces you to compare distinct presentations based on symptom timing and focal tenderness. Patellofemoral syndrome hits young female athletes with subacute or chronic pain that gets way worse with squatting, running, stairs, or even just prolonged sitting. Patellar tendinitis, also known as jumper's knee, gives you episodic pain and highly specific tenderness exactly at the inferior patellar tendon. And finally, Osgood-Schlatter disease targets pre-adolescent athletes right after a recent growth spurt, causing pain with sports that gets better with rest. If the clinical vignette describes a pre-adolescent athlete who just went through a major growth spurt, and they present with pronounced tenderness and swelling specifically at the tibial tubercle, recognize traction apophytis immediately. This is the absolute classic presentation of Osgood-Schlatter, an overuse injury that you must be able to diagnose confidently without even needing to rely on imaging. Now we can see here that patellofemoral pain syndrome, or PFPS, presents as poorly localized pain over the patella, usually driven by quadriceps or hip abductor weakness, or just general malalignment. You diagnose this with the patellofemoral compression test and treat it with NSAIDs, activity modification, and strengthening exercises. But test day requires you to contrast PFPS with acute extensor mechanism failure. Check your risk factors. If a patient has chronic kidney disease, hyperparathyroidism, or is taking fluoroquinolones or anabolic steroids, and they have superior displacement of the patella, that is a complete patellar tendon rupture requiring early surgical repair. On the flip side, what if a dancer or a military recruit twists a flexed knee, feels a severe pop, and the patella is laterally displaced? That's a patellar dislocation from a torn medial patellofemoral ligament, treated with spontaneous or closed reduction.
Rule of thumb: never guess on knee overuse injuries. Always anchor your diagnosis to whether the pain is medial, lateral, or anterior. Iliotibial band syndrome causes poorly localized lateral pain with point tenderness specifically at the lateral femoral epicondyle. We see this constantly in runners. Pes anserine bursitis gives you highly localized medial pain with point tenderness right at the pes anserine bursa on the medial tibia. And prepatellar bursitis presents with anterior, often really boggy swelling right in front of the kneecap. Like I said, location is everything.
All right, shifting over to acute trauma. The classic ACL injury vignette involves rapid deceleration or pivoting on a planted foot, a really loud pop, and immediate massive swelling from hemathrombosis. You'll confirm that ACL tear definitively with an MRI, treating initially with RICE. Contrast this with a PCL tear. The PCL is classically your dashboard injury, driven by a posteriorly directed force on the anterior proximal tibia with a flexed knee. Crucially, and you cannot miss this, if trauma results in a full knee dislocation, you perform an immediate reduction, followed by a meticulous vascular exam, including distal pulses, ABI, and a duplex ultrasound. A popliteal artery injury is the feared complication here, and it will cost the patient their leg if you miss it.
Heading to the back of the knee, a popliteal, or Baker cyst, is an extrusion of fluid from the knee joint space into the semimembranosus or gastrocnemius bursa. It's often driven by underlying osteoarthritis or a meniscal tear. Clinically, it shows up as an asymptomatic bulge behind the knee, but the absolute crucial test day keyword you must recognize is that this bulge uniquely diminishes in size with flexion.
Why does this matter? Well, because of its complications, which is a favorite step 2 trick. If a Baker cyst dissects into the calf, it creates a positive Homan sign. If it ruptures entirely, it triggers acute calf pain, profound warmth, erythema, and ecchymosis. This clinical picture is an absolutely perfect mimic for deep vein thrombosis. You have to use the patient's history of knee pathology and ultimately get a venous ultrasound to definitively separate a ruptured posterior cyst from a dangerous DVT.
Finally, descending down to the foot and heel, you need to translate distinct pain timings and specific tender spots directly into your diagnostic answers. Plantar fasciitis? That gives you maximal pain on the very first steps out of bed in the morning, right at the plantar heel. Achilles tendinopathy presents as burning pain or stiffness just above the posterior calcaneus. Morton's neuroma causes numbness, pain, and a clicking sensation when you palpate the interdigital space between the third and fourth toes. And tarsal tunnel syndrome will give you a distal plantar burning sensation. Oh, and don't forget to utilize the calcaneal squeeze test to differentiate a calcaneal stress fracture from these soft tissue pathologies.
Okay, ankle sprains. When a patient presents with an acute foot or ankle injury, you literally cannot afford to guess when to order imaging. You have to use the Ottawa ankle rules. These are strict, non-negotiable clinical criteria that dictate exactly when an X-ray is mathematically justified following trauma, preventing unnecessary radiation and saving critical time in the ED.
So here are your absolute triggers to order that film. If a patient has pain at the malleolar or midfoot zone, you image them if they have bone tenderness at the posterior margin or tip of the medial malleolus or the lateral malleolus. For the foot, you image if there is tenderness at the navicular bone or at the base of the fifth metatarsal. And regardless of the zone, if the patient is completely unable to bear weight for 4 steps, both immediately following the injury and in your clinic, you must order the X-ray.
Bottom line, commit this top-down localization algorithm to memory. Trust your physical exam findings, respect the precise timing and location of the patient's pain, and rigidly apply rules like the Ottawa criteria. By mapping the anatomy and knowing the next best step in management, you are going to confidently navigate every single orthopedic presentation they throw at you on test day.